Hello, my name is Jean-Louis Vincent. I am an internist by training, but I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, my name is Stefan Schaller. I'm the chair of the next committee of the European Society of Intensive Care Medicine. The next committee represents the young generation of intensivists. I am working in Berlin, Germany, at the Charité University Hospital, and I'm an anesthesiologist and proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist, and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in the intensive care unit. We are working together to fight COVID-19, and together we are intensive care medicine.
Hi, I am an anesthesiologist. I am proud to be an intensivist. We intensivists are working together to fight COVID-19. We are intensive care medicine.
I am a surgeon and I'm proud to be an intensivist as well. We intensivists are working together.
Okay, thank you very much for watching. I'm Amar Gerbes. I'm the chair of the DSA, the Division of Scientific Affairs. And what we are going to do now is I'm going to have some interviews with people who contributed hugely to this Congress. I will talk with Mette Berger from Lausanne, with Jordi Mathebo from Barcelona, with Ib Jammer from Bergen in Norway, and with Dylan de Lange from Utrecht in the Netherlands. Very welcome to you all. Very happy you are there. I hope you have already watched the Congress and you contributed already a lot, I saw. Let me explain what we are going to do. I'm going to ask you all some questions. We will have a discussion all together. And I think our viewers are very interested of your opinion about what you have seen today as a highlight, what you consider as a highlight, or any message you want to give us as the chair of your section. If you want to say something in between, please raise your hand so I can see that you can talk, because we do not want to have what we call a cacophony of everybody together. And if there are disturbing sounds in your environment, please switch off the microphone so that our viewers will have as much as possible profit of this meeting. So let me start with Mette Berger. Mette, can you tell us what have you heard of what would you consider of one of the highlights that you heard today?
Well, I looked at, of course, a session which was on demand regarding phase angle and bioimpedance. And it's very interesting to see confirming data coming out now, showing that bioimpedance is a very simple tool that can complete the assessment of lean body mass in the critically ill patient, which will help us in the future just identify, not in the future, today already, identify the patients who will benefit from nutrition. And you know from your own team, and William Luyards has published just a paper now, how important it is to pick the right persons to deliver high proteins. And if you have a tool to clearly identify the patients with which will benefit, who are low on lean body mass, you will improve their outcome. And this is very important. So that was an important session. And as it is on demand, I encourage people to go and look at that session. I will bring something that I did not hear today, but which will probably, coming from the men's section, be important. It's related to the fact that we are going professional with our speciality. And we just completed a survey, the men's section, about hypophosphatemia. It was a point prevalence survey. And on that day, we collected in 60 ICUs over the world, lowest phosphate values. Our big surprise was that 35% of the ICUs did not measure phosphate daily. And we had a 15% rate of hypophosphatemia, according to the patients being on that very day in the ICU. So clearly there is a lack of training, and the decision of ESICM to support professional training, to have standards, is so important. Hypophosphatemia is a killer. And the men's section is going to continue on this. We need to drive this up and make people monitor. It belongs to our competences.
Can I ask you, Mette, about the hypophosphatemia? Did you also, in your survey, look at the same time whether they would have more, for instance, myopathy in these units where they do not measure hypophosphatemia?
No, medical and surgical patients were evenly distributed. It occurred to all. It occurred to patients on renal replacement therapy, less clearly in the ICUs, which had phosphate-containing replacement solutions. So clearly, there are things to do here. It's about education and maybe asking the industry to change the solution they are providing to us. So clearly, this has consequences, and it is about training. So I associated this with what our president and president-elect said. We have to train people. And monitoring is one of these things. Yeah. So clearly we have to proceed. And it was dangerous. What we found was clearly dangerous to the patients and may constitute, when not measured, a threat to the outcome, a combined metabolic complication of our treatments. Of course, the other thing was in our systematic review that we found that there was no clear definition for hypophosphatemia. So we're going to drive this up. So thank you for letting me have.
Yeah. Well, you're not finished with me yet. Keep with us. I will go to Jordi Mancebo from Barcelona. I think you are, everybody knows you're the chair of the acute respiratory failure section. And COVID is, of course, a big problem, but in terms of research and in terms of action to undertake for patients, this must be a very a good period for you. Can you tell us, what do you consider as one of the highlights that you heard so far, Jordi?
Yeah, thank you, Armand. Good afternoon, everyone. Please, before answering your question, I would like to congratulate you and the people in the Brussels office for making a colossal amount of work and putting an initially traditional Congress into this virtual format. I think that you greatly succeeded in doing this, and thanks so much on behalf of our section. So we are very happy so far with how is going this first day of the meeting, and this morning I've had the opportunity of wandering around different channels, and what I liked the most was a short talk by Margaret Herridge, which was an advice. Well, no, she was telling her thoughts about advices for young physicians, and she mainly discussed about the importance of diversity, especially for her being a woman. And I think that no, we are improving quite rapidly in integrating women in not only in our section but also in the whole Congress. And I think that ESICM is doing very well on this. And she was discussing about the passion, about the respect for others, the importance of cross-fertilization, and the relationship between different disciplines. And it was, I think that the young people who were listening that talk would have enjoyed what Margaret said. Then I went.
If I may interrupt you, I think very important points that you raise. But what I would like to hear something about from you is, because you are very well known, very experienced intensivist, and everybody knows you from your work on respiratory failure and pulmonology. Can you tell us what has changed over the last year from your point of view as a chair of the section of acute respiratory failure? What has happened over the last year? For you, what is the most important thing that you saw happening?
Well, now I'm going to confess something which is obvious. I'm getting older, Armand, and I'm still, I think, I was born in an analogic world, and now the world is coming digital. So this, believe me or not, this has been challenging. But I think that with the help of everyone, even the old ones, we are succeeding in this virtual and digital world. And to tell you the truth, there are plenty of advantages. Of course, I miss a lot to meeting you personally and other friends and colleagues, because again, we are human beings, and I think that by definition we are culturally accustomed to socialize. And now these times of misanthropy are hard, but anyway, I think that this will bring us new avenues of human relationships.
Okay, thank you very much, Jordi. We will switch to Dylan de Lange. Dylan, you are the chair of Health Research and Outcome and Research. Can you tell us something about what you consider as one of the most important things that we have seen over the last year, and what you have heard about during this Congress so far?
Well, thank you, Armand. I think that one of the most important things that is going on in our section, dealing with outcome and dealing with prognostication, is that there's been a huge study called the COVID study, looking at outcome of older patients with COVID-19. And the results are going to be presented in a hot topic session. So that is what I'm really looking forward to seeing presented. And I think that's one of the combined efforts of our section. Really
on Wednesday is that, isn't it?
It's on Wednesday, true. Mm-hmm. So I'm really going to be there and sitting and watching Christian Young doing the presentation, because he deserves all honor for that. And
okay. Yeah, go on.
Another thing that I really liked, which I did today, was I was chairing a session, panel discussion on how to handle the COVID crisis on a national basis. And that was with Geert Meffroy from Belgium and Elie Nicolai from France, which was a really nice and interactive discussion about what went well in this COVID first wave and what should be done better in the second or the third wave. And that was really interesting as well. And we could have gone on for hours like that, but we only had 45 minutes. But really,
tell us, what was it that went not so well? What can we learn?
What was striking for me as a moderator was that both the presenters said that we should not increase our number of beds more than our maximum capacity, our usual maximum capacity, because we are delivering suboptimal care. And there they were pleading to say, well, let's do what we do within our limits and do it right, instead of expanding our capacity to 200, 300% in the third wave, because that is giving a lot of stress to the healthcare workers, and you see a lot of burnout. And that was new for me. And I think that is a very important message for policymakers, but even for our society as well.
Mette, you want to say something about that?
Yes, exactly, because not expanding means that lots of patients who require oxygen and a ventilator will have to be discarded. So it is a debate more than a warning. I think we will have to address this. I listened to your session for a while also, and I heard Elie tell about this. I think it's a problem we have not addressed. It's about ethics, not addressed enough. Of course, it has been addressed. But I mean, when you have 40 COVID patients on a ventilator, as happens in our ICU, while you normally have 35 beds, if you don't expand, how do you do that?
So Dylan, what was the alternative? Because if you say, well, we should not make more facilities for our patients and we dilute the density of the nurses per patient and also the doctor intensivists per patient, we should not do that. But what is then, what happens then?
The truth is, of course, that there is no alternative. And we have been doing what we needed to do in the first wave, but it came at a cost. And that was what was it came at a huge cost for healthcare workers. And the second wave is completely different at least it was in Belgium, the Netherlands, and France, the participating countries to this panel discussion. And what they said, well, the second wave is completely different, but different on a whole other level, meaning that the normal, regular care needed to continue. And that gave a different form of stress. And we need to address that. And we need to be very careful with our healthcare workers. If we want to survive a third wave, then we shouldn't lose all those healthcare workers to stress, burnout, things like that. And this was not the main discussion, but it came out as one of the most striking and, for me, confronting arguments for a third wave. And apparently...
Okay, yeah, go on.
No, apparently it's important because you notice that we're discussing this, and it is something that's really alive among healthcare workers. So this needs to be addressed further.
Yeah, so that brings me to Ip Jammer of the Perioperative Intensive Care. Good afternoon, Ip. Can you tell us something about what has brought it to your section and to the specific subject that you deal with?
Well, one of the things I saw today was something new that really that I really think was striking. This morning there was an on-demand, there was a live session about technology and telemedicine in the University Hospital of the Charité in Berlin, where they do patient visits with telemedicine in other hospitals. And I don't like the idea to disconnect the personal care we give to our patient and having a computer or kind of a robot standing there. But I I was kind of convinced how this will benefit the patient and patient care. So this was really something new that I learned today, and I think we will see more of that in the future, also in terms that we still have a lack of healthcare workers, and how we can overcome this thing. So I can really tell you, you should watch this short video they show there, how they do this telemedicine. That was really striking, really impressive.
Well, we know, we are aware of several examples of that. As you know, in the UK, there are hospitals connected to Australia where they do telemedicine during the night shift. And when it's night in the UK, it's day in Australia. So we had also a similar experiment in the Netherlands a couple of years ago. So how would that be, Jordi? Do you think you can handle with telemedicine a good mechanical ventilation of a patient?
That's a very difficult question, and to me it depends on the context. Ideally, I think that mechanical ventilation need to be controlled by physicians or caregivers at the bedside. Nevertheless, in a context such as this that we have been living in the last months because of the pandemic and a huge, colossal amount of individuals, I think that the possibility of having telemedicine, if not for all patients, perhaps for some of them located in separate or remote places, that can be an extremely good alternative.
Thank you. Dylan, do you think that this can play a role? Come to you, Ip, in a minute. Do you think, Dylan, that it can play a role in the prevention of the imminent disaster that we have of exhaustion of intensive care workers? Can it play a role there to switch to telemedicine, as Ip is suggesting?
Well, I personally think that you should have qualified personnel at the bedside. That would be ideal. But I think that what we can learn with telemedicine is we can learn from our colleagues who are dealing with stuff and are having experience that we do not have. For instance, in the first wave pandemic, Italy was struck very hard in the beginning, and the other countries were not having many COVID patients. And we could discuss with the Italians what was going on, and we could get prepared. And I think that is one of the strong points of telemedicine. It's not really one-to-one care for the patient, but it's more informing your colleagues about what's going on. So I still think that a doctor should be in between the patient and the other doctors far away.
Ip, do you want to comment? And then Mette?
I think there are two things with this COVID pandemic. One is that this was a catalyst of all the changes that were coming anyway. Like we're discussing having internet or digital meetings for a long time, but we never have done them because we always have met in person. But suddenly we have to do a conference, and it works very well. The same with telemedicine. We have talked about this for 20 years, and suddenly we have to do that within a very short time. So I think that this is a good thing with all this pandemic, that it was a catalyst that lots of things we just have talked about, suddenly we need to do them, and we can see in a very short time if this is useful or not. On the other hand, with telemedicine, I see as maybe can be a problem is something that maybe Dylan was also in, so that you have a de-skilling of the patient, of the health personnel who are actually at the patient side. So if you have a telemedicine high specialized doctor, which come in as a robot, and the doctor is sitting somewhere else and is high specialized, why should I have the same knowledge in the hospital if I can get it somewhere else? But that would mean that the hospital that get use of these telemedicine robot will over time de-skill.
Mette?
Again, about training. We had this morning a roundtable with Louis Forney about when to start renal replacement therapy. to do that, you have to insert lines, you have to be able to mount Technica, and we were not able to find, this is not today's question, it's a general question, we were not able to find the solution about when to start a complex therapy that has complications in a world where the competences are very, very different. There are places where you could do it by assistant at distance because the competences are there, but the local competences have to be quite high to be able to take in the comments from a distance.
Yes,
I just agree, Mette.
Okay. Okay, I think you were raising your hand to say something. But coming back to what Jordi said, in order to do the mechanical ventilation very well, it's quite difficult to do that on a distance. Don't you agree, Jordi? So there is still a place for doing and seeing things at bedside, because as Mette earlier mentioned, that if you do not measure something or if you do not look at something, you will not find it. And tell us, Jordi, what do you think about that?
Absolutely. Absolutely. But still, no, and again, even though no, the ideal is to practice mechanical ventilation at the bedside, and as the previous example, renal replacement therapy, etc., etc. We have to be aware of a certain context. And this pandemic put on the table that we are extremely vulnerable, and that perhaps we, in these circumstances, we need to change our main objectives. In this pandemic, I think that the main objective was to save as many lives as possible, even though if the, say in brackets, the quality of care was suboptimal. But again, if I were first time and second, a good or reasonably good view of what's going on in a remote place, I think that I could be able to guide some non-expert manipulating a ventilator with a patient with IRDS, for instance, at least for doing basic things and not harming the patient. I think this is possible.
If I may ask, Ip, because what you have seen in several countries is that the non-COVID care has been put on some sort of hold. Do you think this will have consequences for your section interest, the perioperative intensive care, for the patients that will come in the coming months that are not who do not suffer from COVID?
Yeah, we have seen this here in Norway. We had very little COVID, severe COVID cases here in Norway. But in March, when everybody had a lockdown and we didn't know what would happen, we also restricted a little bit elective surgery. But what actually happened very often was that patients did not come in because they were afraid. So we had a cancellation not from our side, but from patient side who were not coming. So we had quite some delay of elective surgery of patients who were afraid into entering the hospital because they were afraid of contract COVID. And we also saw that the admittance of emergency cases in the emergency room with heart attack, stroke, and other stuff, that also plummeted. And we ask ourselves, where are these patients? Just because we have a pandemic going on doesn't mean that we have less people with a heart attack and with a stroke. So what we are afraid of is that people are afraid contacting healthcare and have advantage of their non-COVID diseases of cancer, and that we will see a wave of non-COVID related illnesses in the next year or couple of years where people have advanced illnesses that will put a strain on the hospital. And I'm, of course, especially interested in surgical patient and the perioperative phase. And due to cancellation of surgery when we had COVID, we have a huge amount of backlog of surgery that needs to be done in the future that puts strain in the hospital on healthcare workers that are
tired.
Worn out. Yes, thank you, Mette, that are tired and worn out already now. And then we have to tell them, well, you know, there will even more people coming. When COVID is over, nothing is over. There will be more. So we need to take care of our colleagues.
Okay, so if I may ask you, because we are coming to the end of this session, if you can give in, let's say, 30 seconds, a message for the members of your section for what they should focus on for the next year to come. What would you say, Dylan, to start with you, and specifically about your section?
Okay, my section deals with prognostication and outcome, and I think that the work that we need to do for the next year would lead to better prognostication of certain subgroups of patients, COVID and non-COVID, and predict quality of care and outcome in those patients. And that's something we are busy doing, but need to continue.
Ip?
My interest is in perioperative medicine, the time between surgery and preventing patients coming to the ICU. So we should work on our surgical population and find things that can prevent patients to coming to ICU, to not putting more strain on that.
Okay. Jordi, in 30 seconds.
Yeah. So first of all, that we are extremely vulnerable, and that this pandemic has made us to realize as well how good we are at dealing with these patients. And now more than ever, the personalized treatment for these individuals is crucial for a better survival.
Thank you. And finally, Mette.
Well, our section will emphasize the importance of assessing the patient's status. Frequently, they are malnourished. We have tools, BIA is one, and the NRS scores, then of monitoring, particularly electrolytes and phosphate, because this goes together, and then to pick the patients who will benefit of high protein feeding. So we will discuss this in our section in the coming months and have a protocol, build a protocol for phosphate.
Brilliant. Well, thank you very much. I hope that all the viewers have got some inspiration from what you said and what you mentioned. At least I did. Thank you very much, and I hope you have a very good evening and be with us again for the coming days. Thank you very much for your participation.
Thank you very much.
Thank you.
Thank you, Arno. Thank you all.
Thank you very much.
Hello, my name is Jean-Louis Vincent. I am an internist by training, but I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, my name is Stefan Schaller. I'm the chair of the next committee of the European Society of Intensive Care Medicine. The next committee represents the young generation of intensivists. I am working in Berlin, Germany, at the Charité University Hospital, and I'm an anesthesiologist and proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
Hello, I'm internal medicine specialist and I'm proud to be an intensivist. We intensivists are working hard to fight for COVID-19. Together, we are intensive care medicine. Thank you.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in the intensive care unit. We are working together to fight COVID-19, and together we are intensive care medicine.
Hi, I am an anesthesiologist. I am proud to be an intensivist. We intensivists are working together to fight COVID-19. We are intensive care medicine.
I am a surgeon and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I'm an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I'm an anaesthetist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm an intensive care nurse and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together, we are intensive care medicine.
I'm a nephrologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
So I am a full-time intensivist and proud to be one. We're all working together in a multidisciplinary fashion to fight COVID-19. Together, we are intensive care medicine.
I am the editor of Intensive Care Medicine Journal. I am proud to be an intensivist. We are working together to fight COVID-19 and to take care also of non-COVID patients. Together, we are intensive care medicine.
I am an anesthesiologist and I'm proud to be an intensivist. Together we are fighting COVID-19. Together we are intensive care medicine.
I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together we are intensive care medicine.
My name is Marco Maggiorini. I'm an intensivist working in Switzerland, and I'm proud to be an intensivist for many years. We are working together to fight COVID-19. Together, we are intensive care medicine.
I'm extremely proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a critical care nurse, and I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19.
I'm a critical care nurse. I am proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are in intensive care.
So my name is Michelle Chu, and I'm an anesthetist and an intensivist, and I'm extremely proud to be an intensivist. We intensivists are working together to fight COVID-19, and together we are intensive care medicine.
I'm Jean Carlet. I am initially an internal medicine doctor and with a specialty in intensive care. And I was head of an ICU in Paris for many years. Together, we are intensive care medicine doctors.
I'm a primary intensivist and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I qualified in medicine and intensive care. Together we fight, together we win. We are intensive care.
Hello, I'm John Kellum. I'm from the University of Pittsburgh, and I was trained as an internist and then trained in critical care in a department of anesthesiology. I work every day with anesthesiologists, surgeons, emergency medicine doctors, all trained as intensivists. I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello to all of you. I am Mette Berger. I am an intensivist with an anesthesiology background. Being myself confined, I am very proud to support and assist the ICU fighting team with distant nutritional counseling and data gathering to enable future research about this bloody coronavirus. Do well, all of you, and stay healthy. Take care.
I work in and run a multidisciplinary intensive care unit in Johannesburg in South Africa and have a background in internal medicine and pulmonology. I'm proud to be an intensivist. In fact, it is a true privilege and pleasure to be in this field every single day. We're working together to fight COVID-19, and together and with passion, we are intensive care medicine.
I'm so proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am a hepatologist and an intensivist, and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
You are now in the corridor.
Your suggestion.
The CAM ICU Scotland with the facial mask is the system that we use.
Okay, thank you very much for joining us, and we will have a very special come together. I have the privilege to speak to two very famous intensivists and past presidents of our society, and we have called this the Stadler and Waldorf commands from past presidents, and I hope that you are both not offended. Jean-Louis Vincent and Yuka Takala, if I can see you, if you will join me, would be fantastic. There you are. Well, thank you very much for your willingness to talk with me and by me, through me with the audience. Well, we will have a very open conversation, and I hope that the audience will hear the things that they would like to know from you. We will talk about what you have seen today in the Congress and also how you put this into perspective in view of your huge experience. This is, of course, a strange Congress in terms of it's completely new. We do things we haven't done before. So I'm very curious about your first impression and what has come to your mind and how you put this into perspective from what happened in the past. And if I may start with Jean-Louis Vincent.
Well, I'd like to congratulate you and your colleagues because you have done a wonderful job so far. I must say that technically it works very, very well. It's easy to find your way through the program. It's easy to follow the sessions. I have really enjoyed it, and I will continue to enjoy it over the next days. Congratulations, it's wonderful.
That's very nice to hear from you, Jean-Louis. You got your first impression?
Yeah, I would also agree with Jean-Louis. It's been a pleasure to use it because really the technical part is quite good, although right away I'm also hearing Jean-Louis sound, so I'll just try to get rid of it.
You in the background, Jean-Louis. And,
I am a ventriloquist, I can talk and
speak. Whole platform, I think, is really quite successful. No, congratulations.
Thank you very much. Well, let's talk business about intensive care medicine, Jean-Louis. What have struck you the most? What you've heard today, and would you comment on that?
Me first, yeah. I liked very much. And you know, that's my usual bias. I like personalization of care. And so when to start renal replacement therapy is really, I think, a very good question. And it's good to hear the opinions of intensivists about this. But at the same time, it's quite disappointing to see that people could start large prospective randomized controlled trials on early versus late renal replacement therapy when we all know that we need to individualize these decisions. If you think that renal failure can be transient, well, you can wait a little bit before you start renal replacement therapy, and maybe the patient will not need it. On the other hand, if you feel that the patient will not quickly recover from renal failure, why don't you start the renal replacement therapy right away before there is major fluid overload with massive edema, before there is hyperkalemia, etc. So it sounds just reasonable to me
to try to personalize these approaches. But, people like prospective randomized control trials, and the results appear in the New England Journal of Medicine, or if they don't like it, it will be the JAMA or the Lancet. So people are proud of it. They say, we published it very, very well. Yeah, but does it really help me with my practice? So I have my concerns about, as you know, about these large multicentric trials targeting mortality, and they are all negative one after the other, unless you focus on iatrogenicity. But otherwise, the groups are so heterogeneous that at the end, there is no major difference between the two groups. I could continue, but I don't want to be the only one to talk.
You won't. Jukka, can you comment on that?
Yes, I think I was following quite intensively the various sessions on artificial intelligence and the approaches to apply that for exactly what Jean-Louis was referring to, personalization. And I think it's quite impressive, the technical, really big leaps that we have taken. But on the other hand, if I think about the first artificial intelligence publications in intensive care were done in the late 80s and early 90s with the technology of the time, but the applications are still fairly meager. We have great technologies, but they haven't yet been really applied in practice in a way that we would say, okay, this is the way forward. So I think that with all the increasing sophistication of these technologies, we should actually go forwards and apply them, and in parallel then try to optimize the technologies. Because if we just improve and improve and improve the technology, and in the end we have the same basic results as were already available 20 years ago, for example, alarms for deterioration in various aspects and so forth, I think we should just take a firm step ahead and in parallel optimize technologies.
So what you say is that a lot of these things that happen with artificial intelligence have not come to the bedside, in fact.
Yes, I think it's the science behind makes major advances. But I mean, we don't see the results yet. It's quite meager, and in many respects could have been already realized a long time ago with undeniably inferior technologies. So we should just now get the technology experts and the clinicians closer together and say, okay, let's do this.
Exactly. So that's why we started last year the new section of data science. Do you think with Jean-Louis that this data science and artificial intelligence will also bring us closer to personalized medicine?
I mean, really, this is what it's all about. I think that's the big advantage or potential. And it all goes into the direction that Jean-Louis was already alluding to, the personalized medicine.
So how come that we focused less on that, let's say, for the past 25 years, and that we have now more focus on that? Do you have an explanation for that, or do you disagree that it was already clear 25 years ago, or what do you see?
Well, I think it's a bit like it used to be with medical records, electronic medical records. Everybody knew that you would need them and they will be put into action. But until there is commercial interest in the area, it will be stagnation. Now we have the big players in IT companies realizing that we are actually getting closer to getting some money out of it. I think this will be the push that will finally bring these technologies also to the bedside. It's a lot is associated with the available funds.
Jean-Louis, we are back. Happy you're back again.
So to address your question, my answer is definitely yes. Artificial intelligence will help to personalize the care of our patients, because the artificial intelligence will actually help our minds to select the most appropriate treatment for any patient at any time. So I am very confident in artificial intelligence, but it's just a way to get there. It's a tool, and I was impressed by the recent study in the New England Journal of Medicine on how to predict catastrophe before even the patient is admitted to the ICU. Dr. Vincent Liu is the second author of that paper, and it's a very interesting paper showing how we could predict catastrophes rather than wait for the catastrophe to arrive and and do CPR and cardiac arrest or run to the patient, etc., etc. And I think it makes so much sense that we must go in that direction. Yuka mentioned that there are several companies involved in this. Of course, it's a new field, and we will make great progress in the future about it. And it's absolutely exciting to see that. So I'm very excited about these developments.
Now, but Jean, let me pick on that a little bit.
Go ahead, Yuka.
Because I think you're absolutely right. Now there is the momentum, but I mean the means and the knowledge required to do that has been available for 20 to 25 years, and it's only now that the commercial partners are in it that we can do something more than just play around with it.
That's correct. That's correct. And I suppose you are alluding to the poor quality of the signal, of the variables you take, and that could be a major issue if there are many artifacts with the blood pressure measurements, with the SpO2, etc. You may end up with a wrong assessment of the situation. Now, if you integrate several variables, if you do not focus only on pulse oximetry, but also on heart rate at the same time, and maybe the temperature at the same time, now you can have a better picture of what's going on with the patient. We have all discussed these false alarms, the alarm fatigue, with indeed the pulse oximeter probe falling down, or the cardiac monitoring system having artifacts. Okay, but over time, I think we have found ways to cope with these problems.
No, I think you're right, but I think also these technologies, like filtering, intelligent filtering, and even simple ways of filtering have been around for 20, 30 years, but they haven't been applied. And I think that now that we have much more flexibility in how to deal with the signals, even do device-specific filtering and all other fancy things, that has basically removed, or actually given the chance to remove most of the issues related to the artifacts. I think it will be also collecting much more data, and especially patients in the wards, so that we can have alarms preceding the severe deterioration. Also, these possibilities have been around for quite a while, but haven't been advanced because the resources for doing big things there were not available. But now that the companies have stepped in, now it's a new opportunity, I think.
Now, you have both a lot of experience how to get people with the noses in the same direction. And as you may know or may not know, we have started in the Netherlands a database with the original data of the patients for COVID first. And now recently we got a 2 million grant from the insurance companies to work on that, to make a database. And one of the principal problems that you see is the non-uniformity of all the data, how they are collected. So if you only look how PEEP, for instance, is coded, it can be in so many different ways that it's only to organize the data. It takes, well, thousands of man hours to work on that. So my question to you would be, how would you advise us to work on that we will get uniformity for all those data, how we collect them, and how they are called in the...
I think that there is a big need for dictionary. It is unrealistic to think that everybody would do the signal acquisition the same way. But if we have a dictionary in place which explains how it is done, then it can be still dealt with. We have, in Switzerland, there is currently a fairly large project in sepsis, where obviously the researchers were confronted exactly with these issues. So starting with, when you plan a project, starting with the dictionary is really the elementary first step. It's comparable to the time when we started to create the first patient data management system, when really we were confronted with quite obvious but still surprising things, such as, if you say blood pressure, what do you mean by that? How do you collect it? What is your time frame? What is the sampling frequency? What is the way of filtering? So it's a huge but very, very important job to make the dictionary.
So how would you get the companies in the same direction? Because we have several stakeholders for this. How would you do that?
Well, I think that one way is certainly these large research projects which have been supported by non-commercial elements, such as in our case in Switzerland, the Swiss National Fund, which is a science foundation, has given a big grant into that. So that will certainly bring in the interest also for the companies, because they see that there's a national or larger interest behind it. But I think it's really, it is clear that the open databases will be the future. I know that, for example, from my former institution, where we had quite a nice artificial intelligence, or actually machine learning project, which was published in Nature Medicine. It was done jointly with the ETH in the technical high school in Zurich, and the whole database was made public. So these large databases started to be available. It's much larger than the MIMIC databases were, and these will come. And once you have them available for researchers, then actually the idea of having proprietary ways by every company, it becomes moot.
Jean-Louis, can you comment?
Yeah, I agree with Jukka, although I would prefer not to see national programs. Maybe Switzerland is a world by itself, but I am very European, as you know, and so I wouldn't like to see a Belgian grant and then a Dutch grant. And I hope that we will work together better, at least in the European Union. And that's what we missed in the COVID-19 crisis, let's admit it. There was not enough coordination. Now we try with the vaccines, but when even in the response to the pandemic, and how we should open the restaurant versus the borders versus the shops, etc., it has been a cacophony, unfortunately, because health is not developed enough within the European Union. But so I would hope to see more European grants, but they are coming. Yeah, there are. And the other thing is that the big companies are really developing indeed their own system. I am a consultant to GE, for instance, and they do a lot. Intriguingly, a company like Roche that makes blood tests basically is also interested in systems that could go in that direction, and also how our information could be facilitated, how we could get more information on our hospital smartphone. That would be a way to go. Of course, we do not need to go to a computer. We don't need to go to the bedside. We could find a lot of information on our smartphone, and including, of course, intelligent alarm systems based on large databases, because, of course, if you want to do artificial intelligence, you need to have the data to start with.
Jean, just a comment on your criticism or comment on the national projects. I didn't say that we should do national projects. I just say that there has been already funds available from national sources, which may be used to leverage then wider collaboration. I'm fully in agreement with you. We shouldn't be limiting these projects to national issues or so. But unfortunately, sometimes the funds are available locally, but then you can do things which should be collaborative, basically with any partner who is willing to join.
Yeah, we agree. Yeah, absolutely.
So if I bring back with you started with, Jean-Louis Vincent, with the early versus late renal replacement therapy, that we should individualize it. We talked about the large databases that we need to have, and that we need artificial intelligence, and so that it can help us to do more personalized medicine for our patients. So now where does it bring us for the near future? Will we have then totally different randomized controlled trials with other types of questions? We now see a lot of platform studies that have been produced during the COVID crisis. You have the feeling that there is a different kind of research for this subject. Will this bring us all together? What changes do we need to make for the randomized controlled trials that we do? Could you both comment on that?
Yeah, the big issue is heterogeneity. That's our big problem. We speak about ICU patients. We speak about sepsis. We speak about ARDS. All of this is very heterogeneous. So it was a good thing about COVID-19 to face a single disease. And yet we realized that COVID-19 is not so homogeneous. Of course, there is only one virus. Okay, maybe minor variants. There is one virus. But we understood that the early phase is not the same as the late phase. Some patients may have a tremendously significant host response. People call it the cytokine storm. Do you like to call it that way or not? It's another word. So I don't think it helps to speak about cytokine storm. But the point is that even COVID-19 is relatively heterogeneous. Nevertheless, COVID-19 is a very, very good indication for platform trials. And congratulations to the recovery group, in particular from the UK. They have done a fantastic job. Discovery, had also contributed. But that was really the good indication. Because the platform for CAP, community-acquired pneumonia, or VAP, ventilator-associated pneumonia, I'm not so sure. I would prefer, Armand, to address your question, I would prefer to do a prospective randomized control trial. Of course, I'm not against RCTs, but a randomized control trial in a relatively homogeneous patient population. Biomarkers could help, or a particular phenotype could help. And I would not target mortality as an endpoint. I would look more at morbidity. I would not discard mortality. Of course, we need to look at mortality, of course. But as a primary endpoint, it leads almost each time to a negative study. Think about it and give me some examples where prospective randomized controlled trials have shown a difference in mortality. I argue that it's only when there is iatrogenicity. The large tidal volume in RDS is the best example. Or prone positioning, it's also an example. You minimize the iatrogenic aspect of mechanical ventilation by putting the patient in prone position. But otherwise, or non-invasive ventilation, yeah, because you avoid the tube. These are the only trials that have shown a difference in mortality. So I would very much favor a trial having morbidity, organ dysfunction as an endpoint. Maybe not the length of stay, because there are also too many factors influencing. Like mortality, that's a big problem with mortality. There are so many factors influencing it. When you, Armand, Yuka, and me, when we enroll a patient in a trial, we already know in 85% of the cases, this patient will survive or this patient will not survive. So you act on 15% of your patient population where you could perhaps influence the outcome. And then the family comes and says, no, my father could survive, but my father wouldn't like that quality of life. No. Or the other way around. You would say, well, let's stop our efforts. No, we want to continue. My father was. So mortality is a lousy endpoint. It's quite clear now, and we hear that at every single session at our meetings.
Yuka?
Yeah, I think it's certainly, Jean would pointed out many of the issues. I think one issue which we still ignore or tend to ignore is that there is a huge variation between the ICUs. And of course, doing large randomized trials, we assume that we would actually take this impact away. But it's quite hard, as long as Jean-Louis was saying, if we recruit maybe 10% or 15% of the patients, the sizes per center, the sample sizes per center are extremely small, and the performance between the centers varies quite a bit. Of course, we could try to homogenize the centers, but the problem, of course, then is the generalizability. Mm-hmm. So this fact that not just our patients, but our treatments and our capabilities to treat vary between centers quite a bit, it makes a fundamental hindrance for really great breakthroughs. And I think that it would be one track to follow, at least, trying to find way, even if it's at the cost of generalizability, but if we can have more homogeneous patient groups, but also more homogeneous centers who then apply these new treatments. Of course, afterwards, the generalizability would have to be assessed.
Well, thank you very much. We are coming to an end, and it was a fantastic discussion we had. I thank you very much. I think the viewers would be very much interested in the last advice of both of you. We are facing still the COVID crisis. People are exhausted. You are both head of departments, a lot of experience in that. What you hear is now that the intensivists and the ICU nurses, they really get exhausted. Can you give us a tip from your experience and knowledge for all viewers for the next coming months in, let's say, 30 seconds? And I start with Yuka.
Pay attention to your staff, spend time with them as much as possible, and try to give personalized support for your staff as much as possible. The needs of people are so different. Despite it, exhaustion will be a problem, but at least investing on the human side of the process will be helpful.
Yeah, the team approach is essential, and everybody should really realize that he or she is supported by the others. It should never be, find your way, I'm too busy, do it. During the surge of patients, it was very clear. In some departments, the head intensivist was looking after 1 or 2 or 3 or 4 patients, asking the others who are less specialized, go there and take care of that patient. No, we need to go with the pyramid, and the person who is most experienced should supervise the others and help them by this good mentorship and good supervision. And this is absolutely essential. Psychologists perhaps could help at some point, because sometimes the human crises are absolutely significant. So the team approach is really very important.
Okay, I must thank you very much for your time and your willingness to help us. And well, you were the first in this specific Stadler and Waldorf session. I hope you appreciated as a sense of humor as well. But thank you for your very wise comments, and hope to see you tomorrow again in the Congress. Thank you very much.
Thank you. It was a pleasure. Bye.
Four months ago, intensive care changed for good in the way it is carried out as well as how it is perceived. COVID-19 was of course the catalyst, and it has dominated our work, overshadowing all we do. We are still fighting this virus and still working day and night to help all the patients in our care. But what has been achieved during these exceptionally trying months is something we should all be proud of. The European Society of Intensive Care Medicine has proven a valuable resource for those who have the power to change the status quo in healthcare across the European Union. During this time, European Society of Intensive Care Medicine has strengthened its connections with EU health, education and finance ministers, as well as EU policymakers at the European institutions. We are pushing hard for the free movement of intensivists so that we are able to work in all EU countries and for our speciality and competencies to be recognized throughout the EU. We are gaining serious momentum, and media around the world has been echoing our call for an army of intensivists to fight COVID-19 and future pandemics. But it doesn't end there. Our society has responded to a global need for expertise in our specialty. As we all learn and gather data about the virus, we have made it our purpose to facilitate the sharing and dissemination of life-saving information to not only our members, but also to the medical community worldwide through a series of COVID-19 dedicated webinars reaching hundreds of thousands of individuals in over 60 countries. And that's not to mention the numerous resulting studies, surveys and other global collaborations. Unite COVID-19, for example, the one-day point prevalence observational study designed to discover more about the burden of the virus in ICUs across the world. So far, 260 centers have signed up, and registration is still open if you wish to take part. Remember, you can find all of these resources on our dedicated webpage, which is full of freely available publications, articles, podcasts and interviews. Finally, I would like to thank you, our members, from the bottom of my heart for your hard work during these unprecedented times. Together we are saving lives. Together we are intensive care.
You are now in the corridor.
Your suggestion.
The CAM ICU Scotland, if the facial mask is the system that we use.
I am an anesthesiologist and I'm proud to be an intensivist. Together we are fighting COVID-19. Together we are intensive care medicine.
I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together we are intensive care medicine.
My name is Marco Maggiorini. I'm an intensivist working in Switzerland, and I'm proud to be an intensivist for many years. We are working together to fight COVID-19. Together, we are intensive care medicine.
I'm extremely proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I'm a critical care nurse, and I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19.
I'm a critical care nurse. I am proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are in intensive care.
So my name is Michelle Chu, and I'm an anesthetist and an intensivist, and I'm extremely proud to be an intensivist. We intensivists are working together to fight COVID-19, and together we are intensive care medicine.
I'm Jean-Pierre Lay. I am initially an internal medicine doctor and with a specialty in intensive care. And I was head of an ICU in Paris for many years. Together, we are intensive care medicine doctors.
I'm a primary intensivist and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I qualified in medicine and intensive care. Together we fight, together we win. We are intensive care.
Hello, I'm John Kellum. I'm from the University of Pittsburgh, and I was trained as an internist and then trained in critical care in a department of anesthesiology. I work every day with anesthesiologists, surgeons, emergency medicine doctors, all trained as intensivists. I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Hello to all of you. I am Mette Berger. I am an intensivist with an anesthesiology background. Being myself confined, I am very proud to support and assist the ICU fighting team with distant nutritional counseling and data gathering to enable future research about this bloody coronavirus. Do well, all of you, and stay healthy. Take care.